Thank you. I'm Dr. Susan Evans. I am a trauma surgeon in Charlotte, North Carolina, and I'm also the Society of Critical Care Medicine representative to this work group. And I am delighted to be able to present our penultimate presenter for this last 2 days. Last year, we had Bethany Kwan as our implementation scientist presenting from the Adult and Child Center for Outcome Research and Dissemination Delivery Science. And so this year we have Dr. Anna Ma, who has been at the University of Colorado since 2016. Before that, she was at Cornell. But since that time, she is a go-getter. She doesn't stop. She has she's a fellowship in health sciences research and implementation science. She has received her master's degree in biostatistics from Columbia University, and she's also been a K-12 scholar within the Accord Center, and has had most of her focus for implementation science on equity. And so she's going to talk about that with us today, as well as talking about AI ethics. Thank you.
Thank you so much for that introduction. I'm really delighted to be presenting today. I'm just going to make sure my slides are in the right mode. So you can see my slides?
Yes, we can, and we can hear you.
Okay, perfect. Yeah, so thank you so much for the invitation to share a few of my thoughts on this really important topic. Here are the learning objectives for the next few minutes. In terms of positionality, I'm an Asian American woman. I'm the daughter of a Burmese immigrant and a white woman from rural community in the US. And I think that background always made me feel as though the US was a place for every kind of person, and that there were opportunities for every kind of person. And I hope it remains so. So I'm going to talk for the next few minutes on how we have opportunities to leverage existing technology to solve some of our longstanding problems in both evidence generation as well as its implementation to improve health outcomes in both high and low resource settings. And these slides are really inspired by a recent brainstorming session a couple of months ago with multidisciplinary experts that were brought together by Dr. Legrone, in which she asked us to think about this question of evidence generation together. And of course, our conversation started off discussing meta-analysis and grade criteria and Cochrane, because that's what we think of when we think of rigor. So like, probably many of you, I started my career as an EBM acolyte. I was trained to believe that the level of evidence pyramid with explanatory RCTs that prioritized internal validity was the gold standard for trial design, and that meta-analysis of those RCTs as the gold standard of evidence. And although this paradigm is still extremely important, we know that there are a lot of limitations to this approach, and that we can actually now feasibly address through pragmatic approaches and leveraging existing technologies. So, explanatory RCTs, very expensive to do. They have poor generalizability because the inclusion criteria are so narrow. So the results don't apply to many patients, and they're most often performed in high resource settings, so have really limited applicability to many parts of the world. And so the realization of these limitations were what motivated the rise of the pragmatic trials and pragmatic research movement, with this famous quote by Larry Green: if we want more evidence-based practice, we need more practice-based evidence. And so pragmatic approaches, we evaluate interventions in real world practice with minimal external research procedures and with real world data sources. And the advantages of these approaches include greater external validity, faster learning cycles, improved cost effectiveness and feasibility of our research methods, and then evidence that is highly applicable to the local context. And so further evolution of pragmatic research is really the concept of the learning health system. This concept was sort of first put forward by the National Academy of Medicine in 2007, described as science, informatics, incentives, and culture aligning for continuous improvement and innovation with best practices seemingly embedded in the delivery process, and new knowledge being captured as an integral byproduct of the delivery experience. And so this idea of a learning health system, which is really aspirational at this point, is now our North Star, where rigorous evaluation is simply part of system operations. It's not a separate sort of research endeavor. So another important concept that's key to this understanding of why generating local knowledge is so important and so valuable is the concept of a complex intervention, which we use routinely in D&I science. So complex interventions are described in the literature as having multiple components that must be implemented in a particular way for the intervention to have the intended effect. Additionally, they are adopted and interact with multiple levels of the organization. And these qualities make complex interventions context dependent because aspects of the context can become barriers or facilitators to high fidelity implementation. And the truth is, if you're taking a pragmatic view and you're evaluating an intervention, a health intervention in a real world practice, that pretty much all interventions will meet this criteria of complex intervention. So even just the act of trying to get a medication that is known to be efficacious to a patient ends up becoming a complex intervention because, the pharmacy has to have it in stock. The physician needs to remember to prescribe it. The patient needs to be able to purchase it and remember to take it. And this concept of complex interventions is just sort of part of how we think of health interventions now in real world settings as implementation scientists. And of course, trauma care interventions are a perfect example of very complex interventions. If you consider, optimal workflow in a level 1 trauma center in the US relative to a trauma center in a low or middle income country, those are very different contexts with different sorts of imaging available, different surgical expertise available, different equipment in the OR that's available. And so the best practice is going to look very different in those different contexts. And ideally, generating evidence in each of these settings to apply to that setting is what I would argue should be one of our goals, and that also it is actually possible to do this. Another class of intervention that our research group is really thinking about are AI interventions. So our group has been thinking about how to leverage learning health system infrastructure and implementation science methods to ensure AI interventions are effective and equitable. AI interventions fit very nicely within the paradigm of a complex intervention because, the AI models themselves really can only they by themselves cannot impact health or the system. They need decision components sort of paired with the model predictions in order to have impact. So I'm going to use AI interventions as an example of how we can leverage implementation science methods and learning health system infrastructure to optimize evidence generation and effectiveness and equity. We can use our implementation science methods like theories, models, and frameworks and contextual evaluations to iteratively evaluate implementation effectiveness and health equity outcomes, as well as dynamic context to perform data-driven adaptations to implementation strategies with the goal of improving implementation and effectiveness. Of note, learning health system infrastructure, which leverage EHR data in a really timely and low burden way, is really what makes these iterative evaluations and adaptations feasible. However, the rigor and robustness of our evaluations are really only as good as the data that is collected upstream in the planning phase, including completeness, quality, and relevance of the data. So while the learning health system infrastructure makes these types of robust evaluations possible, there's a real need to get better data into our EHRs. So now let's turn to an example of one of our current projects that is aimed at doing just this. And I hope it helps illustrate some of the opportunities to advance how we generate evidence using implementation methods, AI, and learning health system infrastructure together. This is an AHRQ funded project led by my colleagues, Drs. Foster Goss and Lee Zhao, and the study is being performed currently at the University of Colorado Hospital Emergency Department. So in this study, the patient can give a narrative account of their social needs while they're waiting to be evaluated by their provider. The large language model then summarizes and categorizes the data captured and puts it into discrete fields within the EHR so that it can be used both at the point of care to provide social needs referrals, and in addition, it can be used at the system level for quality improvement and for research purposes. And one of the things that I'm most excited about with regard to sort of these large language models and their translation capabilities is that this intervention, so the patient can offer this in their social needs information in their native languages, or they can offer it by responding to voice prompt as opposed to a written prompt. So in this way, we can capture these data in non-English speaking and low literacy populations. And this is really going to sort of enhance the completeness of our data. We will be evaluating the intervention using the D&I framework iterative prism, in which we will iteratively measure both context and implementation, effectiveness outcomes, disparities outcomes to understand the progress of implementation, effectiveness, equity, and dynamic context. And then we're going to adapt and deploy implementation strategies based on that interval data to enhance sort of contextual fit and effectiveness. You know, as I wrap up here, the other topic I just wanted to touch on briefly is that came up in our brainstorming session led by Dr. Legrone was a discussion of whether or not you need EHRs in order to do these sorts of evaluations. And I don't pretend to have a definitive answer to this, but I do think that this is something really worth thinking and talking about. We've got to keep in mind that only a fraction of health systems have EHRs globally. So if we limit ourselves to only thinking about these solutions for health systems with EHRs, we're going to be leaving out a lot of the world. And as someone who works, the other thing, just point I want to make is that as someone who works in the learning health learning health system space and practices in a quaternary care environment, we have a lot of projects with our health system where we're trying to do these sorts of evaluations with them, and there's a lot of barriers to leveraging data within the EHR, and they're not technical. You know, most of them are a product of the current incentive structure. The EHR vendors are not incentivized to customize EHRs for the purpose of evaluation or improvement in health outcomes, and the health systems are not incentivized either. These incentive problems are really the bottleneck at this point for the learning health system movement. You know, all academic hospitals have EHRs, but only a handful have anything that looks like, you know, a learning health system. So I'm hoping that some of you that are working in the mHealth space with apps and thinking about potential ways to capture outcomes data in lower resource settings and potentially leveraging AI to enhance data capture in the way that I just described. And you know, perhaps the data capture won't be as robust as our you know, high resource EHRs, but they may be more agile way to capture these data. So just food for thought. And we want to make sure that we're not making perfect the enemy of good, and thinking about solutions for all practice environments, not just the ones that we're currently working in. So next steps to making learning health systems a reality in high and low resource settings. I think we need to realize this is not a technology problem largely, it's an implementation problem. More specifically, it's largely an incentive problem. So for myself as an implementation scientist, I'm very interested in leveraging AI to better measure trust and power so we can develop incentives that really motivate the necessary changes to really get the right incentives in place so that we can really leverage this technology in a manner that improves patient outcomes. So thank you so much for your attention. And I'll leave you with this quote that I think is in line with the themes of the conference.
Dr. Ma, thank you so much. I'm glad. I hope you've resuscitated yourself and you're doing better. Thank you for making time for this even when you got struck, like many of our partners did. We have a few moments for questions for Dr. Ma, so we'll open it up.
Dr. Ma, could you give us a couple of examples of the misaligned incentives that you see and that you think ways to fix?
Yeah, no, I mean, they're really tough problems. It's almost like the technical problems at this point are easier. So for instance, I mean, and you know, I think many of you are probably potentially working in some of in a similar environment to me, but you know, Epic kind of it's running the show, right? And it doesn't have a lot of incentive to be responsive to the kinds of data that we're interested in necessarily capturing. So that's one piece, is just the EHR vendors have a lot of power and just not a lot of incentive to be responsive to our needs. And remember, the EHRs were not developed for, you know, quality improvement or improving outcomes. They're primarily a billing tool, right? So fundamentally, there's a problem there. It's got all this potential, but it's not sort of set up for this. This is not its original purpose. So that's one piece. The other thing is the health systems, they're running on very like thin margins, and they will absolutely measure the things that they are required to measure. But there's, I think, a big lag in what policy is sort of requiring them to measure, and you know, a gap between what they're required to measure and what would really actually make a difference in terms of outcomes. But you know, one of our goals in, you know, learning health system work and D&I is like we're trying to sort of lower the resources necessary to do these kinds of evaluations. So it's sort of easier for the health systems to kind of sort of do the right thing and leverage this technology for the betterment of the patients. So I don't have any perfect answers. I think for us in implementation science, we really need to start focusing on really understanding what motivates change at an individual level. So individual psychology, but also at the policy level, and working on measures to do that. So we're actually right now doing some projects trying to leverage AI to really map out power dynamics, so that we can sort of hopefully create and deploy better implementation strategies to like change these power dynamics and incentive structures. But it's hard work. It's not going to be overnight.
Thank you so much, Dr. Ma. We look forward to learning from and working with you in the future. And rest up.
Thank you.